Hello everyone, today's topic is neuroradiology of brain tumors. We are going to study it with tools like CT and MRI. And MRI is considered superior to computed tomography for the reasons mentioned below. For example, there is no ionizing radiation, there is better display of anatomical relations, there is higher sensitivity for pathology, and easy multiplanar imaging without repositioning of the patient. And there is less contrast media reaction and toxicity in MRI because gadolinium that we use in MRI for contrast is better tolerated by the patients. So the contrast media in CT is iodine and MRI, as we discussed before, is gadolinium, which demonstrates so when there is contrast enhancement, when there is a breakdown of blood-brain barrier, and we have to notify the degree of vascularization in a tumor to identify what type of enhancement is there in this tumor, so that we can categorize it and characterize the different tumors into different classes. So this is an example of enhancement. This is a contrast enhanced image. And here we can see the vessels picking up the contrast and getting enhanced. And this is the tumor that is enhancing so homogeneously. So what are the goals we are going to consider in neuroradiology of brain tumors? First of all, we have to detect if there is presence of a mass lesion or is it not. And second, if the mass lesion if you identify a mass lesion, then we have to find out if it is intraaxial or extraaxial. Then later on, we have to make a differential diagnosis. Is it a tumor? Is it an abscess? Is it a cavernoma? Or is it a multiple sclerosis plaque? What kind of tumor is it? Because tumors are differentiated into different types based on their pathology. For example, gliomas and gliomas are further subdivided into different types based on different types of cells. For example, schwannomas, oligodendrocytes. So we have to classify those tumors, and first of all we have to identify if it is a tumor at all or not. It could be a mass lesion which is an abscess, or it is a cavernoma that is an arterio of venal vascular malformations. Then we have to grade the tumor. Is the lesion benign or is the tumor malignant? And then we have to do it with a mindset so that we can help the surgeon. For example, if there is a preoperative, we have to imagine ourselves in the place of surgeon. We have to find out the extension of the lesion so that we can help the surgeon in planning the surgery. And we have to find out the vascular roadmap. For example, what vessel is supplying this tumor. Next, if the tumor is already treated, for the follow-up, we have to find out if there is any residual tumor after the surgery that is not removed properly, or if there is a relapsing tumor, or if there is a recurrence of the tumor, because some tumors are notoriously known for recurrence. Then, in the routine imaging, what is the plan we go through? First, we have to see the CT. In CT, we have to see the attenuation of the lesion or the density of the lesion. For example, some tumors like lymphoma, they are always hyperdense. And most of the tumors you'll find like they'll be hypodense or heterogeneous, but some lesions are typically hyperdense. One of them example is lymphoma. Next, we have to go to MRI. MRI, in T1, T2, and FLAIR images or FLAIR sequences, we have to find out if the tumor is homogeneous. Then we have to find out if there is a necrotic center in the tumor, if there is associated edema or hemorrhage, or after all these things, we have to study all these things in all these three sequences. T1 for anatomy, T2, we have to find out if it is hyper intense or hypointense. And then we go to FLAIR. FLAIR is very important for the diagnosis because the fluid will be suppressed and you can identify the lesion very well. Next, we go to contrast enhancement. Contrast enhancement will help us after we study the basic non-contrast MRI. And then we have to find out, after identifying the lesion, we have to mention the location of the tumor and the extension of the tumor, like what adjacent places it is extending to, and if there is any vital organ involved in it or not. Then Then we are going to results with conventional imaging. Some images are almost pathognomonic. Uh, like some images are like aren't many. Like if you see them, you'll know it as a this tumor. For example, most of the extraaxial tumors like meningioma, schwannoma, and this is a caustic schwannoma, hemangioblastoma, and epidermoids. These are the extraaxial tumors. What do you mean by extraaxial lesions? They are out of the cerebral hemisphere. That means the meninges are involved or these cells are involved. Okay. Then next is pilocytic astrocytoma, subependymal giant cell astrocytoma, cystic ganglioma, central neurocytoma, colloid cyst, and lipoma. All of these tumors are pathognomonic, have put pathognomonic measures. So now we are going to study these images. I'm going to show you, and we'll discuss these images later on. Okay, so here, what are you seeing? Here we are seeing a T2 sequence first, then T1, then there is T1 contrast enhanced imaging, then diffusion weighted and T2. What we are seeing here is there is this cerebellar peduncle is involved on the right side. We are seeing a well-defined ovoid shaped lesion in the right cerebellar peduncle, which is not enhancing after giving contrast. It is hyper intense on T1 and it is hyper on T2, like most of the tumors. Then there is no diffusion restriction. By studying diffusion restriction, we have to study the ADC. We have to compare a lesion with ADC, and diffusion restriction, diffusion weighted imaging and ADC are always studied together. Then there is this T2 sagittal. All of the above are in the axial sections, and the last one is T2 sagittal. This is the MRS. MRS, we are seeing a choline peak. Okay, what does it signify? We'll study later on. Okay, so discussion of this image. Okay, what are the findings? The first finding is there is focal enlargement of right middle cerebellar peduncle. Okay, so in this image, there is this red mark, red area describing the lesion. There is enlargement of the middle cerebellar peduncle on the right side. And on T2, it is hyper intense, whereas in T1, it is hyper intense. There is very minimal peripheral enhancement. Earlier, we thought there is no enhancement at all. But if we look at it carefully, there is minimal enhancement in the periphery of the lesion. If we compare it with T1, we can see there is minimal peripheral enhancement. Okay, next is elevated choline creatinine ratio. So we studied in this MRS image, there is choline peak. So elevated choline and creatinine ratio. What are the differentials we are going to look for this lesion? First is brainstem glioma. Next is there could be osmotic demyelination, acute disseminated encephalitis, neurofibromatosis 1, and rhombencephalitis. And for this image, this patient was diagnosed with brainstem glioma. Okay, so if there is any malignancy, we studied about choline peak. Okay, so what are the different metabolites we are going to study in MRS spectroscopy? First is the lipids. What ppm value will find lipids? 0.9 to 1.4. Okay, so the last image, the first image, the last one is lipids. When will it increase? These are the products of brain destruction. So wherever there is brain destruction, there will lipid will be peak will be seen. Second is lactate. Lactate is a product of anaerobic glycolysis. Okay, so wherever there is anaerobic glycolysis, we will see a lactate peak. So lipid lactate peak is seen in tuberculosis, for example. Then NAA, neurogenic amino acid, that is a neuronal marker. If there is, it is the component of neurons. It is seen at 2 ppm. Then on the left side is creatine, and left to the creatine is choline. Okay, so if we go from right to left, you have to see that 1, 2, 3, 4 is from right to left. Okay, so the right is on the most right side, we will see lipids, then lactate, then NAA, then creatine, and then choline. Creatine is the indicator of energy metabolism. Because there is a tumor, there is increased energy, like there is more metabolism. So we can see the rise in creatine also, and cell membrane marker is choline. Okay, so in malignancies, what is there? There is brain destruction and there is anaerobic glycolysis. So lipid, lactate, and choline is increased. And the neurons are decreased, so Na is decreased, and creatine. There is energy metabolism. Okay, sorry, this creatine will be decreased. Okay, so if we consider a ratio, Na and creatine ratio, there is, if the normal ratio is 2. If it is less than 1.6, it is considered abnormal. Then Na and choline ratio is normal 1.6, and if it is less than 1.2, it is considered abnormal. Choline is to creatine ratio is normal 1.2, and if it is more than 1.5, it is considered abnormal. That means there is a choline peak, for example, in our case. Okay, then next, this image, the previously discussed image, was of brainstem glioma. What is brainstem glioma? It is an infiltrative fibrillary astrocytoma, not pilocytic astrocytoma or tectal glioma. Okay, so there is enlargement of the pons, and for enhancement, it can enhance or it can also, like, it shows variable enhancement. Sometimes it may enhance or it may not enhance. And there is flattening of the anterior border of the fourth ventricle. What is the prognosis for these patients have with brainstem glioma? The mean survival rate is 1 year. Okay, so the image analysis. First, anatomy. We saw the anatomical location. It was right middle cerebellar peduncle. Then brainstem is involved and fourth ventricle is involved. If we go to that, there is this fourth ventricle. If you see clearly on the right side, the fourth ventricle is effaced, okay, because of this enlargement of the cerebellar peduncle. And brainstem is also involved because the cerebellar peduncle is involved in this. Then MRI, what are we finding? There is altered signal in T1, D2 and diffusion weighted imaging. There is faint peripheral enhancement or ring enhancement. Okay, ring enhancement, the differentials, glioma is one very important differential for ring enhancing lesions. Then MRS, there is increased choline to creatinine ratio. Okay, so what are the complications that can occur? Okay, what we had to see in a patient of brain tumor, we have to look for necrosis, edema, and hemorrhage. Okay, so edema and all these things, they can cause obstructive hydrocephalus because already this is a space occupying lesion and it is obstructing the lumen of the fourth ventricle. So it can cause obstructive hydrocephalus. We have to look for DDs that we studied earlier. Okay, and what were the DDs? Osmotic demyelination, neurofibromatosis, thrombin encephalitis. Then we'll give the impression this is a intracranial space occupying lesion seen in the right middle cerebellar peduncle involving the brainstem and likely a brain tumor, and the above findings are suggestive of brainstem glioma. Okay, now the second case. There is signs of increased intracranial tension, and this is the image of a 10-year-old boy. Okay, again we are having a T2 flared, T1 axial and T1 sagittal, then T1 contrast enhanced in axial as well as sagittal. Here we have cystic lesion and there is a solid component also. Okay, and we can see it is, the cystic component is hyper in T2 and it is suppressant here. This is how we are saying it is fluid component. Okay, and it is involving the right cerebellar hemisphere and it is crossing the midline also. And see, you can see the fourth ventricle here. So we are going to discuss this image in further slides. First of all, what are our findings? There is a cystic cerebellar mass with an enhancing mural nodule. Okay, the solid component that we are seeing is a mural nodule. And there is a mass effect on fourth ventricle. As you can see in this image, the fourth ventricle is pushed towards the right side because of this space occupying lesion in the cerebellar hemisphere on the left side. Next, the differential, what we are going to see. What we discussed earlier was there are some tumors that have a characteristic picture. So this image is juvenile pilocytic astrocytoma. It is a cystic cerebellar mass with an enhancing mural nodule. If you see it anywhere, this in a 10-year-old or in a pediatric age group, then we are going towards juvenile pilocytic astrocytoma. And since it is near the fourth ventricle, we can also give the differential as medulloblastoma, ependymoma, and because of a mural nodule, we can go towards hemangioblastoma, and which is associated with von Hippel-Lindau syndrome. And the other differential we can give is ganglioglioma. Okay, so in this image, what we are marking with the red color is the whole of the lesion, and what is marked in the yellow part is the mural nodule. Okay, so now we are going to discuss about juvenile pilocytic astrocytoma. This is a cystic cerebellar mass with enhancing mural nodule which arises from cerebellar hemisphere and compresses the fourth ventricle. There is little to no edema at all, because some lesions you'll see a lot of edema, disproportionate edema is there, but in this lesion there is no edema. And it may cause obstructive hydrocephalus, which all of the tumors you have to suspect the possibility of obstructive hydrocephalus as a complication. Then it is a WHO grade 1 tumor. That means it is going towards, like, the prognosis is better in grade 1 tumors. Then most common locations are cerebellum. The second is optic nerve chiasma on adjacent to the third ventricles, and the least common is brainstem. Okay, so the image analysis, again we have to study first of all what anatomical location is involved, left cerebellar hemisphere, then fourth ventricle, the adjacent area, that is fourth ventricle, is displaced or distorted. In MRI, what are we finding? There is a cystic mass which we can see in T1, T2, and flare it is suppressed, T2 it is hyperintense. Then cystic mass, then enhancing mural nodule. Okay, as you can see in these images, in the contrast enhancement, the mural nodule that was hypo-intense on T1 is hyper, like that means it is enhancing on T1 weight, contrast enhanced images. Okay, so it is showing profuse enhancement on contrast. That means that is why we are saying it is as enhancing mural nodule. Okay, there is a cystic mass and an enhancing mural nodule. What are the complications? As we studied earlier, it is an obstructive hydrocephalus. Then differentials. Differentials already we studied. There could be medulloblastoma, it could be hemangioblastoma, it could be ependymoma, and ganglioglioma. Then impression, what are we going to give? There is an intracerebellar, intracranial space occupying lesion, and this is a tumor. Most likely it is a pilocytic astrocytoma. Then we are going towards cerebral metastasis. Different tumors can have a primary in brain and they can metastasis to the different organs, or there can be a primary which is metastasized into brain. So if you see the picture of a typical cerebral metastasis, we have to look for primary and we have to go towards the most common location. For example, in males you go towards prostate and females you go towards breast, and colon carcinoma, based on the features of metastasis, you can go towards the different diagnosis of primary. So what is the incidence of cerebral metastasis? These are the most common intracranial neoplasm in adults, 40% to 50%. The most common manifestation site of primary somatic cancer, that is 11 to 35%. Then the latent periods between diagnosis of primary tumor and brain mets. For lung cancer, the primary to metastasis diagnosis time is 6 to 9 months, whereas in melanoma, breast, colorectal cancer, it is 2 to 3 years. Now, the incidence, the primary localization is detected as then 45%, multiple metastasis 50 to 85%, melanoma, lung cancer, breast cancer, we see multiple metastasis. So if you are seeing a picture of multiple metastasis, which is seen in 60% of the cases, we have to suspect lung cancer, breast cancer, and melanoma. Okay, and if you find a single metastasis, we have to look for renal cell carcinoma or a colon carcinoma. Now the sex and age. In males, 35 to 70 years, most commonly seen, and the prostate, if you see, we have to look for bone metastasis mostly, and if you see a cerebral metastasis, you have to go towards look for lung cancer, okay, because there is a very less latent period also. And in females, it is seen in 30 to 65 years, and you have to look for breast cancer. if there is a young adult, that because in males and females both the minimum we are taking is 30 to 35. So if you see a young adult with cerebral metastasis, you have to think of osteogenic carcinoma, Ewing sarcoma, or any germ cell tumor. And in children, it is very less frequent metastasis, less like almost 6%. So the tumors of origin. Any systemic cancer can metastasize to the brain. Most common is lung carcinoma. The next is breast carcinoma, then melanoma, colorectal carcinoma, and urogenital cancer. So the most common is lung carcinoma. Second, we have to look for breast carcinoma, then melanoma, colorectal cancer, and urogenital cancer. Then primary or metastatic pulmonary cancer in 90% of patients with brain metastasis. Then typical clinical symptoms. The typical clinical symptoms in a cerebral metastasis will see the cognitive and personality changes in 34% of cases, then headache in 31% cases, weakness in 24% cases, focal seizures in 19% cases, and instability in 11% cases. The less common ones are 5% will see vision impairment and 4% will see nausea and vomiting. Now, what are the clinical diagnostic pitfalls? So, hemorrhage in mets may resemble an acute stroke. Okay, and if there is bilateral metastasis and there is no displacement of the middle line, then the symptoms, it could be asymptomatic or it could mimic a diffuse cerebral disease, or there is a tonsil herniation which is mimicking acute vertebrobasilar infarction. Okay, so this again we are seeing a case study. This is a 49-year-old man. So this is fulfilling a criteria. This is in the range of 35 to 70 years with acute symptoms which are mimicking vertebrobasilar stroke. As we saw, the mimics are this hemorrhagic stroke, hemorrhagic mets mimic a stroke. So the symptoms are dizziness, instability, headache, and nausea. There is no cancer history. So these are the images we have been given. We are given the flared, diffusion weighted, T1 non-enhanced, and contrast enhanced T1. So you mostly what is the feature of cerebral metastasis? They go towards the gray white matter junction. Okay, they are typically located ring enhancing lesions which are seen in the gray white matter junction. Why? Because there is tapering of vessels which is causing the lodging of the metastasis in those locations. So as you can see, there is this in T1 non-contrast, there are like you cannot see very well what the lesions are. In cerebellum you can see some lesions, but in the cerebral hemispheres it is very difficult to diagnose, so they can be called as iso-intense to hypo-intense. Then diffusion weighted, the diffusion restriction is seen because there is hyper in the diffusion weighted imaging, and corresponding ADC shows this hypo like in the cerebellar hemisphere. Then there is flare. Flare, you are seeing the ring peripheral enhancement, peripheral hyperintense rim and the central hypointense area in the flare sequence located in the multiple locations. Okay, and like centrum semiuval, it is located in the left side, 3 lesions are seen, then 1 in the right side. Then in the cerebellar hemisphere, also in the right side, 2 lesions, 3, 4 lesions, and in the vermis also it is seen, and at the level of ventricles also it is seen. Then on the contrast enhanced T1, as you can see, there are multiple ring enhancing lesions. Okay, so what are the therapeutic considerations? Therapy depends on the number of deposits, okay, and location of mets, the sensitivity of the primary tumor to radiation and chemotherapy, and dissemination of systemic malignancy. Okay, so what we have to consider, we have to calculate the number of deposits. Clearly, it could be possible that some lesions are not seen on the non-enhanced images and you can see the multiple lesions on the contrast enhanced images. Then you have to find out the location of the mets. For example, in this image, the cerebellum was involved. This will cause typical symptoms and it will cause very much problem to the patient. So we have to find out the location of the mets, if there are any vital areas involved or not, and the areas which are causing the symptoms. Okay, so next is sensitivity of the primary tumor to radiation and chemotherapy. We have to find out, for example, lung carcinoma, and whatever the primary is, we have to find out if it is radio sensitive or chemosensitive. So if it is very sensitive to the radiation therapy or chemotherapy, then it is very good for the patient because they don't have to go through surgery and it could be treated very easily. Then next is dissemination of systemic malignancy. Again, if you see cerebral metastasis, that means there is a possibility of metastasis to other organs also. First we have to look at the primary, then we have to look for different metastasis area. For example, liver we have to look for. So we have to find out the dissemination of the systemic malignancy. Now the therapeutic options and prognosis. Surgical resection. After surgical resection, the mean survival time is 18 to 24 months. And the next is stereotactic gamma knife surgery. Okay, so surgically non-removable solitary meds or treatment, alternative in 2 to 6 months. Okay. We can do this gamma knife surgery. So if there is only one meds, then we can treat them which are not removed surgically. We can go through gamma knife surgery in those metastases. Then next is radiotherapy. The mean lifetime prolongation is 3 to 6 months only. Okay. Now, CT, non-enhanced CT. In this, you can see isodense or hypodense edematous areas which are not corresponding to the territories of cerebral arteries. Why we are mentioning this not corresponding to territories of cerebral arteries? Because we have to rule out stroke. Okay, if you see it in MCA area, then we can go towards the acute stroke. Okay. Now, this we are seeing the multiple hyperdensities. So there is high NC ratio. So small round cell lung cancer. What picture we have seen earlier, it was diagnosis, small round cell lung cancer metastasis. Okay, the patient was diagnosed with a primary, which was a small round cell lung cancer. Then intratumoral hemorrhage was also seen. That is why it is causing a hyperdensity. Okay, so if there is any intratumoral hemorrhage, we have to look for the characteristic features of hemorrhagic the characteristic primary, the main primaries which cause hemorrhagic metastasis are melanoma, choriocarcinoma, renal cell carcinoma, lung carcinoma, and thyroid carcinoma. And calcification. If we are seeing any calcification, we have to go towards lung cancer or breast cancer. This was about NECT. Okay, now we are talking about contrast enhanced CT. There is intense solid enhancement or it could be ring enhancement. Okay, different types of enhancement can be seen in a metastasis. The standard dose for contrast what we are giving is 30 to 40 gram iodine. Visualization of additional meds can be improved. How can we improve the visualization of additional meds? As we discussed earlier, some lesions are not easily seen initially, and if we give contrast, some new lesions we can see compared to the non-enhanced or plain imaging. Okay, so how we can improve it? By doubling or tripling the dose. For example, if we are giving 40 gram iodine, now we can give 80 gram iodine. And by performing the scans with 1 to 3 hours so that the enhancement is better. Now, MRI versus contrast enhanced CT. Additional tumor foci on MRI is seen in 20% of cases. This is a case of a female, 70-year-old female, she was a known case of adenocarcinoma lung. Then there was 4 months after combined treatment, we did a follow-up CT and MRI, and there were symptoms like decreased mental status, headache, weakness, and vision impairment. Okay, so what are we looking at here? We can see two lesions on the right hemisphere involving the right temporal lobe, and the additional tumor foci diagnostic capability of MRI is 20% better than CT. Okay. So as you can compare in this image, in CT we can look at only these two lesions, and on the MRI we can look at some more lesions in the center and little to the left. Now this is a study of 52-year-old female with the headache and right side leg paralysis. The morphological diagnosis was squamous cell of lung carcinoma, which was diagnosed as the primary. Now we are given non-enhanced T1, diffusion weighted, and FLAIR images. we can look at the lesion in the right cerebral hemisphere. Sorry, left cerebral hemisphere is also there. And this is a case of this 44-year-old female with mental retardation, dizziness, and seizures. As you can see in this image, there is a lesion in the right cerebral hemisphere, a well-defined lesion with surrounding hypointense area, likely due to edema. As then there is some hyperintense foci seen in the left hemisphere also. Now this was again a case of 71-year-old female with headache, cognitive speech disturbances, 8 years after combined therapy, and the primary was diagnosed as a breast cancer, and the clinical diagnosis was ischemic. So morphological diagnosis, carcinomatous, encephalitis. This again is a case of 45-year-old female with headache, cognitive and speech disturbances. The morphological diagnosis was breast cancer, metastasis. And here we can see the leptomeningeal spread, dural spread, and subependymal and parenchymal spread. As we can see in the lining of the right ventricle, the left lateral ventricle is completely obscured. There is midline shift also, and we can see the enhancement in the TOF as well as contrast enhanced even. Okay, here also we can see the same thing. And this also, there is multiple lesions. Now the routine imaging in gliomas, the basis of diagnosis and differential diagnosis. What is the basis? Benign, diffusely infiltrating astrocytoma is homogeneous with minimal edema and absent contrast enhancement. There is no contrast enhancement in astrocytoma. In benign, diffusely infiltrating astrocytoma. And if the anaplastic transformation is there, how do we identify it? By the presence of necrosis, edema, hemorrhage, and contrast enhancement. Here we can see. Okay, so there is the contrast enhancement. Now the ring enhancing lesion. What can be the DD for ring enhancing lesion? It could be a necrotic glioma, it could be necrotic metastasis, it could be abscess or multiple sclerosis. If you see multiple ring enhancing lesion, if you see single ring enhancing lesion, it could be a glioma, it could be metastasis, it could be abscess or multiple sclerosis plaque. If you see multiple lesions, then it could be inflammatory, infectious, and for tumors, it could be multifocal glioblastoma, it could be lymphoma, and again, after these primaries, we have to suspect metastasis based on the age. Now, the basis of diagnosis and differential diagnosis. The main problem we are having is grading of diffuse infiltrating astrocytoma. You have to differentiate necrotic lesions, metastasis, gliomas, abscess, differentiating between malignant glioma and metastasis, radionecrosis versus tumor recurrence. Now, DWI, why do we use DWI? To differentiate glioma from lymphoma, differentiate necrotic glioma, metastasis from abscess, to differentiate arachnoid cyst from epidermoid cyst, to differentiate glioma from lymphoma. For example, in lymphoma, there is low diffusion because of hypercellularity. The diffusion restriction is seen in a strong hypersignalar diffusion is weighted imaging. Again, this is an enhancement on diffusion weighted imaging. So this is a ring enhancement is seen. Again, these are the peripheral enhancement. This is the homogeneously enhancing lesion. So crossing the midline meningioma. This again, it is extra lesion. Now, this is a perfusion weighted imaging. This is a glioblastoma multiforme with areas of hypervascularity. And the second one is low-grade pilocytic astrocytoma with areas of hypovascularity. Okay. Now this again is seen in the areas of right cerebral hemisphere. This one is in the left side with the extraocular dilatation of the ventricles. Now there is no enhancement, but relative cerebral blood volume is elevated, so it is likely a high-grade glioma with choline peak. Now, perfusion weighted imaging, why it is important to differentiate malignant glioma and metastasis. Okay, in glioblastoma, the CBV in the peritumoral edema is high. That means there is growth. In metastasis, it is low. That means there is vasogenic edema. Now, GBM versus lymphoma. Lymphoma, there is leaky blood-brain barriers. Therefore, the CBV is not very high. Again, this is post-radiotherapy. We have to find out if there is recurrence or necrosis. Then again, we have to see the perfusion weighted imaging. In tumor, it is high. If there is nodule, then it is low. Then it could be a possibility of radiation necrosis. CBV negative, though we found out on the biopsy, it is necrosis. There is low CBV, also to contralateral white matter. So perfusion weighted imaging is helpful in differentiating low-grade glioma from high-grade glioma, glioma from metastasis, glioma from lymphoma, and recurrence from radionecrosis and inflammatory changes. MRS is useful. We have to study the choline creatine ratio, choline NA ratio, and NA to creatine ratio. In low grade, there is normal NA. In high grade, there is absent NA. Thank you, everyone.